Okay. Good afternoon, everyone. I'm really sorry for the delay. I'm Arna, your moderator for today's session. Before we begin, I'd like to extend my heartiest holy wishes to everyone celebrating and a very warm Ramadan Mubarak as well on behalf of the whole PsyConnect team. I hope the season brings you happiness and a lot of delicious sweets your way. Now, let me start with a little confession. I have always been a mystery enthusiast. As a kid, I was obsessed with Agatha Christie novels, and even today, podcasts somehow bring me joy. There's just something thrilling about piecing together scattered clues, connecting dots, and finally seeing the whole picture unravel. And when you think about it, case formulation in psychotherapy is quite similar. Each piece of a client's history is like a clue in a grand mystery. When put together correctly, they reveal not just the what, but the why, helping therapists chart out a roadmap for healing. Which brings us to today's session, an introduction to case formulation, from puzzle pieces to psychotherapy journey. We're incredibly honored to have with us today Mr. Jasbir Singh Sir, a clinical psychologist, RCI certified expert, and fellow at the Washington Baltimore Center for Psychoanalysis. He has worked extensively in this field, untangling complex psychological narratives and helping clients navigate their mental health journeys with precision and care. So, without further ado, let's give a warm welcome to Mr. Jasbir Singh Sir. Sir, we're very excited to hear from you today.
Hi, good evening. Uh, Sorry if I don't pronounce your name right. It's Arna, right? Arna.
The,
Is it right?
yes.
Yeah, all right. All right. Um, Dear, I can see seniors and also I can see I think few of my colleagues and I'm very new to most of you. But thank you so much. I'm under the weather. I'm not doing well. What a I woke up sick yesterday basically. Like what a tragedy to wake up sick on a holy day. And so here I am, but I will try my best. Uh, like I have, I really want to thank Shubham and also the Psych Connect team for giving me this platform, this opportunity. And I would like to, like, this is one topic which is very close to my heart. And also, um, I want to tell you that as it's already been written there, it's an introduction. So, uh, since I'm assuming that most of us, like we are students and also some are experts and some are already doing therapy. So, and so I don't really know like like what is the proportion of people doing that. But since it's a basic, for those who doesn't know anything about it, it will be like something new to learn. Those who are already practicing, it's like a revision for you guys. And I like I I begin. I mean I think that discussions are always helpful. So there is something which I can learn from you at the end of the session. Any comments that you have, and also if there is anything which I can share, which I think I can share from my clinical experience, I could also share with you guys. Right? So I will be sharing my slides. Do I have the option to share my slides?
Yes, sir.
Oh, it's written you are not allowed to share your screen. How do I
Um,
do that?
just give me a
Oh,
minute.
all right, all right. It's done. Thank you. All right. Can you all see this? Uh, is my screen shared? Um,
It's not yet visible, sir.
all right.
Yes, it's clear now.
All right. Cool. So the topic is an introduction to case formulation from puzzle pieces to psychotherapy journey. Um, this is little about myself. Ida has already shared. Basically, I'm a clinical psychologist and currently doing a fellowship. It's an online fellowship at Washington Baltimore Center for Psychoanalysis. Something personal about me. I am a long distance runner. I run half marathons in the country and also have participated in marathons. So this is something about me. And if you want to know about my professional work or about me, you can check me out in LinkedIn. Well, so this is a question. Most of my presentation I've taken from a book known as Psychological Case Formulation by Tracy D. Ellis. So he has asked this question, and I thought that this is very relevant question to ask. So how do you know what to do in psychotherapy? Um, and there is a sub question here. It says that in the concrete situation in which you are sitting across from a suffering individual who is seeking your help, who indeed may be relying on you to show them a way into the future, how do you know what to do? Um, so is there anybody who can tell me if you have done therapy, if you have seen patient, if you have helped in any way? What do you do? How do you know what to do?
Anybody who wants to answer can unmute themselves and then answer the question. So Ayushi Agrawal says that it depends upon assessment and formulation.
All right, that's wonderful. We got something. So Tracy else says that to be precisely, we don't know what to do in these situations, whether to say, whether to give some advice, suggestions, or listen, or anything. But it's the plan that we do, and that plan later on we'll see that is a case formulation that we decide how to proceed and what to do in those kind of situations. Now, I think when it comes to psychotherapy, if you see in today's world, you must have heard. I think I've heard a lot of people saying this. I've not directly heard this, but people say that uh, psychologists charge money for talking, and you must have also heard some different statements like it's just a talk only. What's so special about it, right? And you have also come, like you might also have also seen people these days who claims to cure depression and OCD in 5 days workshops. And these advertisements are quite popular on YouTube. And so-called coaches who pretend to be therapists, in fact, they are not. Um, so these are the situations, like these are the things we are seeing in current scenario, that this whole field, which is so precious, is becoming something which is being abused, um, just like that. And there are some questions from a professional standpoint of view, like what are the evidence of psychotherapy? Why is it just talk, or is it more than that? And to them, I have few answers, and um, I want to tell that psychotherapy has its basis on neurological findings, right? There are a lot of things which occurs in psychotherapy. We are not just talking. There are a lot of things that happens, and indirectly or directly, new attachment patterns are being formed. People learns to model empathy. People learns new things, new strategies, new activity. There is fear extinction, and that's what Weldon and Kay has found in their short article, which is published in Psychiatry Times. Also, if you want to read more, there is a meta-analysis of psychotherapy efficacy. You can read on by Smith and Glass. They have given this, and the third citation, which I've cited here. Here's one of my favorite neuroscientists in the world. Here's Eric Kandel. This paper specifically, I have taken only principle 5. So it says that insofar psychotherapy or counseling is effective or produces long-term changes in behavior, it presumably does so through learning by producing changes in gene expression. Very careful, gene expression. So you can see it's like a molecular level that these things are happening that alter the strength of synaptic connections and structural changes that alter the anatomical pattern of interconnection between nerve cells of the brain. So, so these are few of the evidences. There are a lot of evidences these days where you see that we have evidences from neuro uh, logical perspectives too, that how things are changing. So anything which you learn, we know the basic findings of neurology is that anything you learn, new synapses are formed, and a lot of things are learned in those in the sessions. So indirectly or directly, something is getting changed. Maybe maladaptive things are getting changed to adaptive things. Some patterns which were not helpful earlier are changing to something helpful, right? So we are not doing therapy. It's not something which are just doing for the sake of doing it. There is a substantial evidence to back this up. Now, since I've provided you a base that unless we unless we know that what we are doing is not credible, how do we even proceed, right? It will be like fooling people. It will be like doing a malpractice if we don't have evidence. So case formulation, since we know something about psychotherapy and evidence, now we can proceed to what is known as case formulation. Now I was searching. There is a book by Sperry and Sperry, Case Conceptualization and Case Formulation. I searched the literature and I couldn't get a single citation which differentiate between the two, like what is a case conceptualization or case formulation. Although in other books it's referred to as case conceptualization, and most of the book writes at a formulation, and some use it as a change, like interchangeably they use these terms. But for this slides, for this lecture, I'll be using the term case formulation. Now there are a few definitions. It's the it's the first definition. There's a definition by Butler, by Tracy Ells, and there is a division of clinical psychologist definition. Now, if you see on these definitions, um, there are few things which you can notice. The first definition says that formulation is a provisional explanation of hypothesis. Um, if you read the second definition, it talks about is a tool used by clinician to relate theory to practice. Then Tracy Ells becomes a little specific in mentioning which are the domains, which are the criteria. Um, and then division of clinical psychology becomes little more comprehensive in their definition, which provides like a summation and integration of the knowledge that is acquired through assessment process. So uh, these are the definitions provided by different like authors and theorists. However, I just want to highlight that if people ask you what is a case formulation in simple terms, you can simply just say that it's a hypothesis, it's just an explanation about someone's patterns of behavior or thoughts, uh, linking them to the earlier case history, the earlier experiences of their childhood, or it can be the current situations as well. Now we have come to definitions. Now, butlers, uh, now what's the purpose of formulation? Why we need that? Um, this will come again and again, and I'll be reviewing this. First thing is Butler says when clarifying hypotheses and questions. Second is understanding, like providing an overall picture or map. Third is prioritizing issues and problems. Which are the issues, which we'll see later also that does all the problems need immediate solution or immediate cure? Sorry, not cure, but immediate remedy or strategy like interventions. And then is planning treatment strategies and selecting specific interventions, which are evidence based for sure. Then predicting response to strategies and interventions and predict difficulties. Determining criteria for successful outcome, very important. Thinking about lack of progress or troubleshooting and overcoming the clinician bias. So these are all the purpose of a formulation. Um, Moving to the next slide. Now this is a fictional Whitney like case. I just for the sake of explaining two things, I just wrote this. So it's just fictional in nature. Um, so Mr. Roshan, a 40 years old married man with MTech level of qualification, who is currently unemployed for the last 2 years. He has two children and lives with his wife and his children in New Delhi. Roshan was referred to me by a psychiatrist for psychotherapy. On interview of the patient, reported complaints of low mood, sleep disturbance, intrusive and recurrent thoughts of cleanliness, and repetitive hand washing multiple times in a day for the last 8 years. He reported history of past psychiatric treatment for the same. His parents were divorced when he was 12, and his younger sister was 10 years of age. His mother passed away 2 years ago in a car accident. He feels guilty and sad for not able to see her for the last time. He reported a history of physical and sexual abuse in childhood by a relative. He has only disclosed about this incident to few people, including me. He has a supportive wife and children. However, he feels guilty of not able to work and provide to the family. He reported he likes chess and enjoying going to temple, but frequency has decreased. He has few friends at work. MSc finding revealed preoccupation with guilt, pessimistic thoughts, and intrusive thoughts regarding dirt, and acquiring an illness with great free insight. So this is a fictional case, but when you read cases like that, uh, you already should have questions in your mind. Uh, that first thing is symptoms and problems. What are the symptoms that you can see? What are the presenting problems that the patient is presenting to you, right? This is one thing. Now, once you know these are the problems, now you want to know based on his history, based on findings, that what is the diagnosis? What are the possible things which any evidence-based manual has found for this? Then next thing you want to do is you want to formulate a case, like you want to see uh, that how his personality or how his experiences, how his temperaments, how his conditions, how his education and other things explain these things. And then you decide treatment, that what would be the ideal treatment for this patient that you're seeing in front of you, right? So these are the things, and if you combine these things, this solves this puzzle that I would say. But out of these things, a formulation is a very important thing. And Why formulation is important, I'll tell you later again. Now, since we have got a basic of these things, now I want to get to a. There are many for your knowledge. I want to tell you that there are a lot of different formulations for each psychotherapist. But today I'm not going to talk on those formulations. There is a different formulation for psychodynamic therapy, CBT, and they are different. But the case formulation template which I've used is by Tracy Els, and it's known as integrative model of case formulation and therapy. And I found this to be very helpful for at least for the beginner level. And also it can be used, of course, by anybody from different therapy modalities. Um, all right, so I'll be using the highlighter here. All right, now if you see a lot of boxes are there, uh, I'll simplify them for you, and I'll be discussing them like individually also. So first thing is gather information. If anybody comes to you for help, you want to know as much as information about that person. That's your first step. Then you formulate, and in under the formulation, these things comes. You create problem lists, you diagnose, you develop explanatory hypothesis, you plan treatment, and then the final step is treatment, and of course, termination. And you also have to monitor your progress if you see that therapy is not progressing anymore. So you have to keep monitoring your progress also, so that you have an objective standard to show to your patient, and also your patient knows that this therapy is working or not. Now, so these are the things which are here. The first step is gather information, right? So let's move on to the single um, like headings here. I'm sorry. So gather information. Usually, I did my MPhil training from RML Hospital daily. Usually, any patient comes to us, we have to take a detailed history of the patient, and usually it's done in a form of interview. We sit down, we ask uh, things, information about the patient. Now, just the basic information. What are the information that you need? You ask about their social demographics. You ask about the signs and symptoms, the history of present illness. You document the elective history, the academic history, um, any family history, sexual history, comorbid personality, and uh, you also use the use of a mental state examination. So this is one way. Another thing is that we also assess using psychometric testing, like in some cases where we want to know about the personality, for example, we'll be doing a personality assessment. We do a collateral history, like we take from the the, the informants. We would like also to know history from the significant people, like their previous, if they're taking previous treatments, so of course the previous prescriptions will be there, so you'll get some information. So these are the various ways where you gather information. Now, what is more important when you're doing a psychotherapy therapy and formulation is that there are two types of information: processed information and narrative information. Processed information is basically what you're presenting to me at this moment, what you're talking to me, like the facts, um, like what you feel at this moment. But narrative for information, this is important, but narrative information is also very important. Basically, it's um, if somebody did this to you, I want to know who said what and how did you respond to that kind of conversation. So it's basically a narration that I would also want to know, so that it can give me an understanding the kind of communication that person is having, the kind of words have been chosen to say certain things, and how he feels about those things, right? So these are the process and narrative information under this big heading known as general information. I hope till now I'm clear to you guys. Um,
Yes, sir.
Right. Thank you. Mm. All right. Now, under the next heading formulation is create a problem list. Now, this is interesting. And initially when I started my training, uh, I was having difficulty uh, that whose problems I'm discussing here. The problems which I see or the problems which a patient have. This is very important because there is a tendency for clinicians that sometimes uh, what they think is to be a problem might not be the problem to a patient, and especially what diagnostic criteria manuals does is that you just want to put a checklist, or you have low mood, you have this and this and this. Oh, this is the issue we need to tackle, and we don't take consideration of the person who is in front of us, and that's very important. There are some problems which are known as red flags. Problems, and when I talk about red flags, it can be suicide, violence, neglect. These are SOS problems which require immediate intervention, right? So we need to be very careful with these things. Regardless of any therapy you practice or anything you do, you always do ask about suicide and violence or anything, all those things. These are very important. And later on, also, if you practice, I think this will be mentioned in your confidentiality also. That you can only breach confidentiality in on those cases when you think your patient is going to harm himself or going to harm others, and when those are the cases that comes in confidentiality later on. So these are red flag problems. Another thing is now problems can occur in different domains. Uh, if you have heard about Angel's biopsychosocial model, I love the fact that he clubbed it and used this whole dimensions. That we are not seeing an individual from a biological perspective. We are seeing an individual from a social perspective and also psychological perspective, like combining these three. So when it comes to self-functioning, um, self-functioning can include behavior, cognition, affect and mood, biological and existential. So problems can exist in these domains. Let me get you an example. For example, in behavior, now somebody behavior can be excess, behavior can be less. There will deficit in behavior. For example, in hallucination, what happened is that which was the normal, something is more is added, a behavior, right? He's saying things. He is getting aggressive, which was not there earlier. So there is an increase in the behavior. Deficit means a person who previously was going, meeting his friends, he was going out and hanging out, but now he doesn't do anymore. So there can be excess deficits, or there can be abnormal behaviors. When it comes to cognition, now we can have cognition, we can have cognitive distortions. Our concept might be slightly distorted. We might have self-esteem issues, the way we relate, the way we think about ourselves. In affect and mood, of course, it can be overregulated, underregulated, and biological. Um, it can be any issues like a genetic issues, that problems that one can have. Existential has to do with death, bigger things in life. So there are patients who comes to you and they are like, I want to be happy. I'm not happy at all. What's the point of living this life? And so where do you club those points? So there are bigger questions, bigger problems that are there. So there are some existential problems in this regard. Now, problems can also exist in social and interpersonal functioning. So people can have IPR issues. IPR is basically interpersonal relationship issues, and attachment issues can happen, right? A lot of these things can happen. And last comes in societal functioning. Basically, legal things. If somebody is going through legal battles, it can be divorce, it can be other things. It can be war. It can be acculturated stress related to culture. Um, and this, I'll emphasize this point later on also, that how we have to take culture in a context. We have to understand a person from where he's coming from, and how we can sometimes we what we seems to be a normal thing for us cannot be a normal thing to others. So these things are there. Poverty can be an issue also. So these are the bigger, these are the problem list, right? Like in all those domains. Now, as I said to you that I don't decide these things, but I decide with my patient. We discuss these things. These are the issue. Sometimes a patient would give you something else, present you a problem as something else, but that is not the real issue. That is the wrong syndrome. Like he's like taking you away, far away from other issues, which is not very important. So it's like trying to hide or maybe resistance initially. So this has to be taken care of. So I hope we are clear with this when we are creating a problem list. And as I said to you, problems have to we have to create problem in a priority. Like if we see the person is not eating food, in the case of anorexia nervosa, or in a case of a person who is threatening himself to kill, we have to take those cases in priority, and that's how we move on. Now, diagnosis. Um, diagnosis is important, uh, and but diagnosis also has damaged a lot of things. Uh, because I've seen diagnostic, like there are pro and cons to this concept. Let me tell you this. You guys must have heard about DSM-5. I'm assuming you must have studied if you're. So DSM-5 is there. Now we have a text revise like 5, and this there is also an updated version of this. This is known as text revised. ICD-11 is already available, um, and but I don't know whether you guys know this or not. Beside these manuals, there are also other manuals which are not majorly used, but they exist. So I want to highlight this to you. Something known as PDM2, Psychodynamic Manual, second edition. There is a research domain criteria. That's the DSM. There's an alternative criteria of uh, um, like the research domain criteria. In England, the Division of Clinical Psychology, the British Psychological Association, but though they have come up with this manual known as Power Threat Meaning Framework. So they don't see illnesses like how ICD and DSM sees illnesses. They talk more about how uh, the power or the way political structures are there, how the threat to their personal security, and all those things contribute to these things. So that's another version of this. So my point is not to tell which is good and which is bad, but as a students who are curious to know things, I would highly suggest that you please read on this and you form your own understanding about these things. Since we are using DSM-5 and ICD-11 mostly, ICD-11 mostly in our country, uh, so I would, and DSM-5 also. Um, so I would like to speak on these two things. Now, until DSM-2, DSM-3 in 1980s, I think DSM-3 has come up. Um, DSM has been inferential, dimensional, contextual diagnosis. But as from DSM-3 onwards, 4 and 5 and 5TR right now, it has become more categorical and descriptive. What does it mean? That there are certain slight of symptoms a person has, a person doesn't have the symptoms, if doesn't fall into this category. So this person is suffering from depression. If doesn't fall into this category, this person is not suffering from that. But earlier it was more influential, that it was theory related. Dimensional means that we're not saying the symptoms, the illnesses. Uh, like absent category or not present category, but we are seeing them as like in a dimension. Everybody has some sort of illness, but there is a degree to it. There is an intensity to it. There is a kind to it. And context is very important. Like if somebody can be suspicious, like if you go to a new city, you might be suspicious. You might has difficulty in speaking a language. It doesn't mean that you have some sort of illness or not. So the context was very important, but that is not the case at the moment. So I usually ask this question. I would like to ask this question also to people. This is nothing sort of right or wrong, but I just want to ask, what is depression? Anybody can say. Anything you know about depression, you must have heard.
Good afternoon, sir.
Yes. Uh, yes.
I think
Please.
depression is something related to sadness, a feeling which is there for a period of minimum 2 weeks.
Right. Okay.
And so
Okay.
loss of interest and pleasure in activities which we once or the patient once used to enjoy a lot. Now there's no pleasure or interest in those activities.
Wonderful. Wonderful. So you mentioned the sadness of mood, right? And loss of activities. Um, Now, if I ask you, what is sadness of mood and what is loss of interest?
Sir Ipshita Basu has replied that it's persistent, pervasive sadness of mood with
Uh-huh.
anhedonia, deranged biodrives, and negative
Yeah.
cognitions.
All right. So I want to ask
I've,
Arna.
I've heard that another version. Depression is the pressing down of
Mhm.
certain emotions and behaviors that are favorable and healthy for the individual.
All right.
This was a
All right.
psychoanalytical version,
Understandable.
Jungian psychoanalytical version definition of depression.
Okay. Thank you,
Emotions,
sir.
feelings, or behaviors that are pressed down.
Okay. Right. Uh, Thank you for sharing your ideas. I wanted to speak to, especially to people who gave me definition related to DSM and ICD. So many people talked about persistent low mood and all. Now, if I ask you what is persistent low mood, what will be your answer? Okay, inability to feel pleasure or happiness. And what is that? See, I'm going circular in this. When I say anxiety, what is anxiety? People would say, oh, palpitation, difficulty breathing, and all this. When I ask what is that, and they say, oh, this is anxiety. This is what happens with uh, the manual currently, that it doesn't have a theory basis. And somebody has said here that the psychoanalytic thing, what does it mean? So what I'm trying to say is that if there is a theory behind it, what's happening, the symptoms are not just symptoms. They have a story behind that, and that has occurred, right? Now, I'm not saying that DSM-5 and ICD-10 shouldn't be used. That's not at all saying, because they have worked very hard for that also. But you have to understand that these are the shortcomings of these manuals and diagnostic systems. That's why we have a case formulation, which tries to understand a human being in a very comprehensive and a holistic manner. Now, what are the advantage of having a diagnosis? There was there was a patient of mine, I think two or three patients. They were very happy. When they will come, they would say that, "Oh, uh, I have BPD, I have BPAD." Somebody would say, "Oh, I have OCD, I have read on this, it's like that." So labels are just given like that, and it's such a condition. It's such a sad thing to know that people live with those labels. If people are not explained the reason, like what are those things, uh, they will simply just live with them. So it's a skill of a clinician to actually psychoeducate an individual. What does that mean? To some patient, giving a diagnosis can be a relief because the person doesn't know what he's suffering from. Once he comes to know that this is the illness, it can be a relief. But to some, it cannot be a relief, right? For us, clinicians, it helps us to understand something better. For example, if I to be honest, we don't have much time, right? A lot of things have to be done, especially in a government setups. So when somebody has written a diagnosis, like a provisional diagnosis or anything, I come to know, oh, what does that mean? Another thing is that I would read more on that organize and retrieve information about that psychopathology. Right. Another thing is that it's used by courts, school, prisons, and many school agencies to determine eligibility for societal services. Uh, so many, if you see the Mental Health Act 2017 and RPWD Act, uh, people do get some benefits who are really sick, who cannot function really well. There is a criteria to that, which I'm not going in detail. So these are helpful in those kind of cases, right? But a equal balance should be a discern, like you should be prudent and discerning when you're making a diagnosis, disclosing a diagnosis to someone. And this is one part of the formulation. Next thing is formulation. Now we come to the third part, that is explanatory hypothesis. Now, what are my sources? How do I know which therapy works? What are the things? Uh, how do I understand a patient? Um, Somebody has raised their hand.
Yes, sir. Sir, I just wanted to have a correct definition, like you asked, what is sadness? So, in your
Okay.
view, how do I say what is sadness, sir?
So I'm not saying there is a correct definition of that. What I was trying to what I was trying to uh, tell you is that unless sadness is how do we view sadness? Like for example, if I feel sad about something or you feel sad about something, they cannot be two same kind of things we are experiencing. You might be sad because of something else. So without a context, you cannot know what your sadness is all about. But in general way, it's more like a negative, unpleasant state, I would say. I hope it's clear to you.
Thank you, sir.
Yeah, if you have questions, please, I would surely have time of discussion also. So let me just complete this. Right. So now theory, we have psychodynamic theories, which talks about the unconscious, the id, ego, and superego, the psychosexual stages. And let me speak a little bit here about, um, see, the moment some people hear Freud and they just shut down. Let me tell you that psychoanalysis and theory, of course, Freud has begun with something, but doesn't mean that it has restricted to himself. It has gone revisions, and there are more researches, there are more evidence now. And uh, so, please, I would like to tell to people who still hold these notions that psychodynamic is not relevant. Uh, it's not the case because there are many new theories which is coming up, and psychodynamic is not one theory. There is a combination of different theories. Like it has um, Freud's model, it has object relation, it has self psychology, it has relational model, etc., etc. Now we have cognitive behavioral approach, which talks about how we perceive uh, determines the way we um, react to situation. Maybe the cognition. It's not what happened to us, but the way we perceive things. And then there is behavioral talks about the reinforcement. It talks about like uh, punishments and etc. etc. There is a humanistic approaches. I've not listed out all the therapies here, but I've just there are some models which I've listed here. Now we have these are the theories, and then we have evidence for molecular genetics. We have epidemiologies, studies, and different other evidences that we have about the different theories and different illnesses. Now, what are the components when you're formulating a hypothesis? Like you want to know, right, what is happening to the person. So one is precipitance. When somebody comes to you with an illness, um, in the case of Roshan, something has happened. Like it was not very clear, but just imagine that his mother passed away and then his symptoms increases. So that can be a trigger that time. Um, and then this origin, predisposing factors or risk factors, that maybe the earlier childhood has been traumatic. There was difficulties at home, absent father, and so this can predispose people to have certain kind of problems. Then resources. When we're formulating a case, we want to know every person has a talent or ability or something beautiful about themselves. There are internal resources and external resources. So, for example, in the case of Roshan, he has a MA, is a M.Tech degree he has. So that's a resource that shows that he's intelligent. That shows that he can still work. Um, Another thing can be that external uh, resource can be that he has a supportive wife and he has friends. So he has resources. So we make use of those things. And also he likes to play chess, right? So we use those things also when we are making a formulation. And there are obstacles, of course. They can be internal obstacles and external. We have to be very careful in this. Now, internal can be defenses for sure. The person is not willing to share a lot of things. External can be that a person stays very far. A mother who you see a client and the next session doesn't come. Now, you have to also understand that how far does he stay? What is the financial situation? What are the problems, external things that is acting as a barrier to that person? So all these things has to be taken place, and then we develop some core hypothesis. So as I told you, this model specifically is not about a particular therapy, but like like a combination, like it integrates most of the theories and their understanding. So like in the case of psychodynamic. Uh, in the case of Roshan, we can know about the object relation, how his earlier relationship, like how he perceived himself to be his objects. In the case of cognitive appraisal, like um, he's washing his hand, what does that mean to him? Or functional behavioral analysis, basically, what are the reinforcement for doing that behavior, right? So these are the core hypotheses which you form based on the knowledge that you have. Please hold on with me. We are almost at the end. Now, last the formulation part comes is treatment. Now, research first, Lambert. Client is estimated to explain 40% of the variability in outcome. So it's not only therapy skills or the techniques, but also patients or client. Uh, even their variability and their characteristics do explain a lot of things. Now, in this case, um, when you're talking about treatment, some patient can be they can have reactance, like they are not willing to take this therapy. They are not willing to sacrifice their self autonomy. They don't want others to tell them what they do. So the clinician has to be very careful in those kind of situations that what intervention should work for this patient. Now, a client can have preferences. We all have preferences. Mostly, I've seen few patients in RML, but uh, that they would like to see themselves in they want themselves to see to a female therapist, or some patient want to see themselves to a male therapist. So they can have preferences like therapist role, therapist characteristic, and treatment characteristics. Another thing you have to take in context is cultural literacy. A psychotherapy should be adaptable. He should be flexible and maybe know a little bit more about the culture that he's practicing that. Stages of change is very important. Readiness, the next topic we can see here. We have to know that in which stage our patient is. Most of the patient, especially in the OPD I was seeing, most of the children will come to treatment. They would say, "मम्मी ने भेजा है, पापा ने बोला था आने के लिए." And people who are suffering from uh, like illnesses related to psychosis, uh, like schizophrenia and for example BPAD, etc., etc. So they do not have insight. So they would say that they don't have any problems. The problem is with others, and they don't have problems. So people with alcohol abuse, uh, like use disorder and dependency, etc., they will also say that nothing is wrong with them. They're doing fine. So stages of change is very important. And Prochaska and De Clemente has given a trans-theoretical model. If you have studied health psychology, it's also there. So this model is used in various ways. It's used in motivation enhancement therapy also. It's used here also. Now it has 5 stages. Does anybody know what are the 5 stages of this trans-theoretical model given by Prochaska? Um,
Is it pre-contemplation, contemplation? That
yes, yes, yes.
I don't remember the next three.
All right. It's pre-contemplation,
I guess
contemplation. Yes, please.
determination, preparation, and
Yeah,
maintenance.
right. So, most of the patient, thank you so much for listing out. You have beautifully done it. So, most of the patients, when they come, they are already in contemplation stage, like they are considering. And most of the, when somebody is sent from court or somebody is sent from home, mostly they are pre-contemplation because they are not, they think that nothing is wrong with them. So, to each of this stage, we have to assess their motivation. We have to know in what stage they are so that you are aware that how to work with them. So that is very important. Now we goal identifications. Similarly, how we identified the problems, we identified goals. So there are in the goals there are two subheading, which is known as process and outcome goals. Process goals can be short term and long term. Process goals are your therapeutic alliance that you're forming, or maybe it can be short term, can be the crisis intervention that you're doing with a patient who is suffering from, like, who is trying to harm himself or herself. And outcome goals are the outcome only once you're able to do, like, once you're able to use these process goals. And outcome goals can be like short term. You want to, like, for example, in the case of uh, Roshan, he has difficulty with the guilt now, and also difficulty finding a job. Maybe we can work on finding. Initially, we can work with guilt, and then we can, in the long term, we can help him with his job finding, which can, and also we can do ERP, like exposure and prevention therapy, like for his like the obsession and the compulsion that he has. Right? So the whole point is that intervention is tailored according to the unique needs of the patient. No size fits. Not every same, like everybody gonna be receptive to the same thing. Now, once you have done all these things, um, uh, you you continue with the treatment. You practice those things depending on the sessions. If there is a manual that you're using, like CBT has some set of uh, session things, and like they are every therapy has their own ways. So based on that, you can discuss, you can use those manuals, and you can review them. Now, when we talk about goals, goals has to be specific and non-specific. They have to be measurable. They have to be achievable. They have to be realistic, and they have to be timely. So these things has to be kept in mind. And now is basically termination of treatment. So you terminate based on the review that you're having. Now, previously, when you do, you must have administered a test. Like, for example, a person suffering from depression, you must have administered like a BDI, back depression inventory, or YVOX, for example. So they are, what do you call? So they give you a baseline, basically, like, so that later on when you check, you review, you come back and see what the progress, so that you and your patient can see objectively. Um, I think there is someone at the door. Uh, if you, I think, just hold on, please.
Sure, sir.
All right. Am I audible?
Yes, sir.
All right. Um, so this is what formulation um, is all about, and how do we know something is changing in the patient? We are saying that they are able to regulate their emotions well. They are able to have good interpersonal relationships. They are able to achieve the goals that they have for their lives. And these are some of the standard. There are other like objective measures also, which are not listed here, which can help you to know what the progress is all about. This is I wanted to share with you. This is few pointers which Nancy McWilliams, one of my favorite, um, uh, like uh, like I would consider her as a mentor. I have not met her, but I would love to meet her one day. That we have so much inclined towards discussing mental illness that we have forgot what mental health is all about. And as an individual, so she highlights few of the things. That means sense of safety and trust in oneself, others, and the world. There is a sense of agency. The person has a volition to do something, to achieve something. There is a sense of continuity. Like everybody has a narrative, everybody has a history about themselves. So there is a continuity between them. There is a healthy, positive self-esteem. There is affect tolerance, and there is self-preservation and altruism. Like we think about a community, we think about the higher purpose. Um, there is acceptance about one's flaws. There is acceptance that what things can be changed and what cannot be. And there is a capacity to love, work, and play. So these are the things which are some of the indicators which can also give you an idea that the person is moving towards a change or not. I would like to end my slides with this quotation, which I found relevant, um, but uh, understand this in the context. Right? It's by Carl Jung. So he says that to decide when to apply the one or the other method rests with the analyst's skills and experience. Practical medicine is and has always been an art, and the same is true of practical analysis. True art is creation, and creation is beyond all theories. That is why I say to any beginner, learn your theories as well as you can, but put them aside when you touch the miracle of living soul. Not theories, but your own creative individuality alone must decide, right? That you know your theories. I'm not saying that you should really discard your theories or your whatever you have learned, but understand that when I am talking to another human being, he's a human being like me in a flesh. So I have to have, I'm not seeing that person as something inanimate. So this is very important. And psychotherapy in itself is a very, um, I would consider a sacrosanct profession. And if you're doing well, and that's amazing. And I just hope that we will be able to do well and able to serve and make the individuals and the country and maybe the world as a better place to live in. And with these few thoughts, I end my presentation and some references. And thank you.
Thank you so much, sir. I think the quote also answers the question that whether one approach is fit for all or not very correctly. That every case uses its own unique connotation of different theories and different sort of approaches. Now, I would like to open the floor to audience questions. There was one question to begin with by
Yes.
Ipshita. She asked that if you can explain what sense of agency and sense of continuity means.
Self-awareness is okay. It's basically, especially, I would take an example of a disorder when it comes to persons suffering from um, personality disorders, and to be specific, in the borderline, like borderline personality disorders. So there is a view a person sees. There's a identity issues that person has that doesn't have a core, um, like coherent idea about themselves, and there is a discontinuity between experiences. But when me and you, as like we see ourselves, we don't see ourselves as only one part at a particular time. Right? We see ourselves as a whole of who we are, continuing from our childhood. So that's what basically it's talking about. And agency is basically that you are able to practice your volition, that you can contribute something to fruitful to the society, um, something like that. I hope it answers your question. I'll be um, for that. If Shita, if there's a Nancy McWilliams, if you in YouTube also you can listen to her podcast. Like she has done a podcast with someone, and I actually I couldn't find the exact. I have read about the reference. So maybe Jonathan Shedder also talks about that about mental health. So please, if you can read that, that also will be very beneficial to you. Yes, Nancy McWilliams. Thank you. Yes, great.
Okay, are there any more questions? Or also, can you please list down the, or like if you can share your screen again for the books that you've told about during the session?
Oh, okay. I have not listed the books in my session, but I would like
There
to.
were two books
Uh,
that you told. The first
okay,
one,
it's a psychological case formulation by Tracy L. I can type it. It's going to be a blue color book by uh, American Psychological Association. Can you see? I'm sorry, can you see? Okay, it can't be seen, but I'll just
you can
read
just
out.
dictate the spelling of the author's name.
Okay, uh, the author's name is Tracy, Tracy.
Yes, sir.
Tracy D is the separate. Okay, D L and EELLS.
Okay. What's the name of the book, sir?
It's known as Psychotherapy Case Formulation. And there is another book. I didn't use this as my primary text, but this is known as Case Conceptualization um, by John Sperry and Lance Sperry. Ifshita, yeah, I think this is also the one, and there is another one like by the same author. It's a blue in color. No, no, sorry, no, it's not. Wait, I'll just me out. So I can do this. Mm, right, all right. I've typed it. Right.
Yes, so it's there.
Yeah. And if you want to read particularly for a particular therapy, right? So, like for example, psychodynamic therapy. So Nancy McWilliams, the author I've already given, she has also written about case formulation from a psychodynamic perspective. So this is about that. But this Tracy else gives you a very introductory picture about what actually happens. So if you can begin with that, and that uh, then you can basically add on to your knowledge gradually. Is there any more questions? Any more comments you want to add something which I think I should also be aware of? Uh,
So there was a question that was raised in our Google Forms regarding the session. It was that how do you handle cases where a client presents conflicting or incomplete information? Like, is there any particular strategy that you can use to dig them down without breaking the ethical barriers?
uh, if they provide us a very incomplete information, that's what you're asking me.
Yes, yes, sir.
Usually, like we, as if I'm a clinician, I would like to uh, know like the history from multiple sources about themselves. Of course, they'll be reluctant initially, uh, but what I feel is personally is that it's a therapeutic alliance. The stronger the therapeutic alliance is, the more trust is built, I think. So initially, it might not be. For example, I presented a very idealistic picture to you that you this will happen and your case formulation will be done and then the two session or the third session will begin. That doesn't happen that way. Information it will keep coming again and again. You'll be talking about something and suddenly that patient will mention, "Oh, I remember this in my childhood." And what will you do? You have to refine it again. You have to put information, right? So it's an ongoing process. Like that's why we say it's a hypothesis. It's not a concrete uh, like plan. It's a plan, of course, but it's not like something we say that it's like a definite plan that we have. So the stronger your alliances is found, also the stronger your alliances, your patient will be able to trust you with that, and then that's how it can work.
Okay. So are there any more questions? Anybody? Okay, so then before we end, there's one question that I would like to raise. Like,
Sure.
for aspiring therapists or clinical psychologists listening to this, what's one piece of advice that you would like to give to them to improve their skills or improve their skills in case formulation, particularly?
You're asking like aspiring clinical psychologists, right? It's so. Um, I think I would technically there are two answers to that. Technical one is the more technical, that's based on a competence base. That is that you need to read more on a particular case that you're dealing with. That you read more about that, discuss that with your peers if there is a need. Of course, maintain the confidentiality. That is one thing. But what I understand, what in the initial session, what I want is that I want the patient to tell me a lot about themselves as a free-floating thing. So maintaining that humanness is very important, which I feel. So of course that comes with practice. I would say that it's not that you would get to learn in one way. So read so that the more you read, you are also following the ethical guidelines, which API's guideline that you have to be a competent person to actually give psychotherapy. If you're not being competent, then you'll end up like giving those 5 day workshops and whatnot.
Okay. Thank you so much, sir, for sharing your expertise with us. As we wrap up, I think we conclude that a well crafted case formulation is not just about diagnosis, it's about understanding a person's whole story and what's like determining what will be their path to healing. Just like in any great mystery, every detail matters, every minute little insights brings you closer to the whole truth. So thank you so much, sir, and thank you so much to everybody being such an engaged audience. As earlier, as earlier, we requested you all. We would still appreciate it. We truly appreciate that, and please, we would like to know more ideas from you. Feel free to email us your suggestions at the following email ID. I have sent it in the Google chat box. Thank you all. Thank you, and thank you so much. We're very honored to have you today. Keep questioning, keep learning, and keep solving these little psychological puzzles. We hope to see you again in another insightful session. Thank you so
Awesome.
much.
Thank you. Thank you,
Thank
everybody.
you, sir. Get well soon.
Thank you.
Thank you.